What's up, podcaster? Today I have Dr. Amanda Kirzner on, and she is a double board certified in anesthesiology as well as obesity medicine. How are you doing today?
Good. Thank you for having me.
For sure. So before we dive into the nuts and bolts of what I wanted to talk about and a few questions I had for you, give me a little context on how you got into doing what you're doing now. As far as, were you interested in becoming, getting into the medical industry as a child? I mean, how did this all play out to where you're at now?
I was interested as a child. My father is a doctor, but he went back to medical school the year I was born. And I feel like people who went back to medical school, a lot of them appreciate their careers and they like it more than people who started at a young age and they went into it for the wrong reason. So he was always a very happy doctor while I was growing up. And doctors' children, either they become doctors or they become something completely opposite. And both my brothers and I all went on to become physicians.
Okay. Well, so you have, how many siblings do you have?
Two brothers,
Gotcha.
but we're close in age. We're like a 3 kids in 3 years kind of situation.
Okay. So now you're in the medical industry, and now which one comes first, anesthesiologist or obesity medicine? How does that
So
play out?
anesthesia came first.
Okay. So tell me why you chose that field.
So the thing about medical school, it's a little strange. You only do certain rotations. So it's 2 years in the classroom and 2 years in the hospitals.
Okay.
That was traditionally what it was. There are some programs that are making it 2.5 years in the hospitals, but let's go with the traditional route. So I had 2 years in the classroom, 2 years in the hospital. They make you do core rotations. So OBGYN, they make you do surgery, they make you do internal medicine, pediatrics, psychiatry. I don't know if I'm missing any. The other specialties, you kind of have to seek out yourself. You have to say, wow, that sounds interesting. I'm going to apply and do a rotation in that specialty. Then you get exposure, you see if you like it, and then you apply. Residency is something you have to apply to, and you're able to get it based on your grades and your test scores and how you did during your rotations. So not everyone could wake up and say, you know what, I want to be a neurosurgeon. You have to have really high grades and test scores and do well on your rotations. So I had exposure to anesthesia because my father was an anesthesiologist. He really liked the field. So I went in thinking, you know what, this is something I want to explore. And I went and I did a rotation in it. There are other fields that, looking back, I think I would have liked equally just as much, but I really didn't have exposure to it. Like, I could love ophthalmology. I've never done a rotation in it. I'm not sure. But I give anesthesia for ophthalmology procedures. So now it's like I'm thinking, because I think I'm more exposed as an anesthesiologist to different specialties than I was even back then as a medical student.
I mean, that makes sense. Well, real quick, let's give some context to them on like listeners and viewers that are watching this on what anesthesiology is. I'm aware, but like I know you use it in other applications besides just surgery. So if you want to like elaborate on some of that a little bit.
So anesthesia, we're kind of everywhere now. You want to know what I do in the operating room, or you want to know where else?
Just the umbrella of everything.
So basically any procedure you need an anesthesiologist to do. We're in surgeries, we are in GI procedures, so colonoscopies, endoscopies, even more advanced procedures than that. We're on OB, labor and delivery, we're giving epidurals, we're doing anesthesia for C-sections. We are in the electrophysiology and the cath labs, for interventional cardiology, people in anesthesia for that, of course. At the big hospital I was at, I was giving anesthesia for people getting MRIs who were claustrophobic.
Really?
Decided they'd like to take a nap during their MRI. I don't necessarily agree that that's the best thing to do, unless there are some people that really need the anesthesia. Yeah. People with Alzheimer's, people who can't sit still. The people coming off the street, who are claustrophobic, I feel like there might be a better way, but no judgment, but we do it for that. We're doing anesthesia in a lot more specialties where anesthesia wasn't necessarily given in the past. Basically, people want to be pain-free and they want to be asleep for anything that might cause discomfort.
Yeah.
So we're expanding. Obviously, where our main roles are, we're traditionally in the operating room and in the ICU, where we
Okay.
manage critical care patients and ventilators and all of that.
So during doing this field, basically, you get to touch on a little bit of every piece of the medical industry, basically.
Every specialty, yeah. We work with a lot of different specialties. You can do a fellowship and sort of practice one type of anesthesia, or you can be a more general anesthesiologist. So I do pretty much everything except cardiac.
Okay.
I don't do open hearts. I
Gotcha.
learned it as a resident, but most people who are doing open hearts now do an extra year in order to do that, but it wasn't something that interests me.
Gotcha. Okay. And so from there, how do you get into the obesity medicine thing?
All right. So I was always, it's not a really traditional route to go from anesthesiology to obesity medicine.
Hmm.
Basically, at this point in time, you can become board certified in obesity medicine if you're board certified in any specialty.
Okay.
Now, I'm pretty sure that that is going to change in the next few years. Sleep medicine was another specialty where it used to be like that. You're board certified in one specialty and you can do conferences, CMEs, and take a board exam after a year. And that's how it was for obesity medicine. But after a few years, it changed into a fellowship. So like more training beyond your
Okay.
residency in order to become a sleep medicine doctor. And fellowships already exist for obesity medicine. So I'm pretty sure that's where it's going to go in the next few years. But I was always interested in dieting and nutrition. I do have a master's in public health that I got
Okay.
at Columbia. So obviously obesity was a big topic. It's a big public health issue. But it's also a really big issue in anesthesiology.
Okay.
Because the physiology of a person's body really changes when they're overweight or obese. And
Mhm.
right now in 2020, about almost 40% of the population is overweight or obese. So there are certain medications that work differently in the body if someone is overweight. There are different mechanisms of how people breathe under anesthesia and different maneuvers we can do if the patient's overweight, but it's much more difficult to take care of a patient who's overweight or obese than it is to take care of a regular patient. So I just became more interested in that. I also do a lot of bariatric surgery. So that's another reason I was also very
Okay.
interested.
Well, yeah, I mean, because that's honestly that's what I want to talk about a lot today is the fact that doing those things like, of course. Now, what would be the percentage? You said that over 40%. Now, what classifies someone as obese?
Okay, so so there are three classes of obesity. So there's class 1, class 2, and class 3. So class 1 obesity is someone whose body mass index is a 30 or above.
Okay.
And so many people in the population, like people who you would look at, you wouldn't necessarily even think. I mean,
Right.
is body mass index the best way to, it doesn't take certain things into account. It doesn't take muscle mass, it doesn't
Hmm.
take, bone structure and those things, but, it's a pretty good indicator of, the patient's height and the patient's weight.
Right. Right, because you'll have people that are a bit shorter, but maybe a little more muscular and have a little more weight on them, and they could classify those people as overweight. I've heard that in the past too. So.
Right.
But so me myself, I've been passionate about the basically the health and fitness industry for a long time, and I have a lot of experience in personal training, MMA, competition, stuff like that. And I really wanted to talk about it's it's one of those things where you go back to. I really want to talk to you because it's the obesity like medicine factor of it, like putting medicine behind treating obesity issues, and I'm bringing this up not to raise a flag, but basically saying, okay, so if someone, like you hear this a lot where someone says, okay, hereditarily, I am overweight. And as a society, we know that sometimes may be a factor, but at the root issue, diet and exercise, isn't that the first step to combating this disease?
Yes, but there are a lot of genetic components and hormonal components to obesity.
Okay.
So that was a lot of like the exam I had to take to become board certified. So
Right.
it really is partially genetic. And of course, it's what you eat and how you exercise.
Yeah.
And that's, you really can't combat your genetics, but
Of
you
course.
can work on what you put in your mouth
Of
and
course.
how you move your body. So sometimes I feel like when people say, oh, I'm just predisposed, well, it might be more difficult for you, but that's not the only reason that
Exactly.
you're going to gain weight.
Yeah. Don't stop trying to combat it. I mean, of course, if that's something that you're pre-genetically disposed to, then you're going to have to work harder.
Right,
You know,
exactly.
and I feel like a lot of times we hear this and we see this, and I'm in Louisiana, so I'm in a state that's really obese,
Yes.
and so it's like one of those things where family and past generations of people who don't consume enough water, who are eating too much fatty foods, who are eating processed foods. I saw a post on your social media earlier. You were talking about eating holistically or natural, but then trying to sell me some kind of shake. You know what I mean?
Yeah.
What are
So,
your thoughts on
I
that?
mean,
What has just overcome these pyramid scheme fitness fads, these processed new supplements and all that? What are your thoughts on all of those things coming out and constantly being a challenge for people who may be exposed to saying, okay, let me try this 30-day solution that really isn't going to solve anything?
so I think, well, any weight loss is good weight loss if someone's overweight or obese, but they really should look to do something that is going to be something that they can stay on.
Yeah.
Because if anyone does any kind of diet or any kind of eating plan and they stop it, they're obviously going to gain the weight back. And I think it's important that people know who they are, meaning, some people can't tolerate like a low carb diet.
Yeah.
So if you asked me what kind of diet would make me lose the most weight, right? We're not talking about maintaining the weight. We're not talking about anything. I would say low carb, higher fat, low carb, but I'm not a person who could ever stay on that, right? It's just not how I eat. It's not what I like. Of course, you can't always eat everything you like when you're trying to lose weight, but
Right.
I think you have to know who you are as a person and then tailor a plan with regard to, what someone is going to do. If you put someone on a diet or an eating plan where they're going to have to cook every meal and they don't want to do that or they don't have time for that, then they're not going to stick to it. You have to be more realistic. But as far as like weight loss schemes or whatever, I mean, they might take a few pounds off, but it's not going to be a longer term solution.
Yeah. I mean, I understand that. So what are your thoughts like going into, I guess, what are the most common cases that you see dealing with obesity patients?
I mean, every single patient's obese for every single case.
Okay.
I mean, I
Well,
used to
yeah,
do a
that
lot
makes
of,
sense. That makes sense. I guess what are the most common cases, like where is it like well, you'll just elaborate on that, I guess.
I mean, I do, like I said, a lot of weight loss surgery. I do a lot of orthopedics, so knee replacements and hip replacements, people who are
Ooh,
obese with a lot
those are
of,
okay.
pressure, and then they get wear and tear on their
Yeah.
knees, and
Yeah.
then they replacements. But,
Can we talk about
I
that real
have
quick?
discovered,
I don't want to cut you off, but I may forget about this. So I want to talk about that. So if we're talking about weight loss surgery, or basically, the lap band or whatever it may be that you guys are performing.
no more lap bands. We're done
Whatever.
doing those anymore.
Okay. Well, I don't know. I have no idea. But what are the replacement for that? What are they doing now?
A sleeve gastrectomy. So the lap band is not great for a lot of weight loss. And what can happen is it can erode into the stomach and cause a lot of swallowing problems, nausea, vomiting. We're actually taking out a lot of lap bands. And
Okay.
they've caused a lot of adhesions, which is scarring, and a lot of problems. So instead of doing that now, I mean, there are still places that are doing that, but they shouldn't be.
Right.
We are doing a sleeve gastrectomy, which is basically altering the anatomy inside and making the stomach very, very teeny, so they can only tolerate certain foods
Right.
at a time. But weight loss surgery is more than just altering anatomy. It also changes a lot of hormones in the body.
Okay.
There are a lot of hormones, ghrelin, leptin, adiponectin, that have to do with weight loss and weight gain. It's very complicated. And the weight loss surgery actually alters a lot of the hormones. And it, gastric bypass solves diabetes for a lot of patients. And it's not just because they lost weight. So
Right.
there's a lot more to it than.
Okay. Well, I mean, I've heard some instances of having those surgeries, the patient then in 5 years becomes overweight again because they've come.
Yeah, they can.
Yeah.
Because I mean, even if you're doing that, like there's always the potential to gain weight. If you're gonna go off your, plan, if you're gonna eat
Right.
foods that you shouldn't,
Right.
you can still like, stretch your stomach and you can gain weight. It's gonna be a lifelong battle. Having the surgery is not like the end. It's
It's
just
a
the
temp.
beginning.
Right. It's part of a plan moving forward, because I feel like I've seen it multiple times where people have the surgery or the knee replacement thing. I've worked with people in the past that I was in the oil and gas industry for a long time. You have a lot of individuals that are older up in the age and been in that industry for a long time. They've gotten to where they're in a supervisor position to where they're sitting still a lot and they're consuming the same food, not getting the exercise, have knee replacement, and then still are gaining weight, and it's just horrible. And then I've also seen people to where they've had, the weight loss surgery and then basically continue to eat horrible, like what put them in the position to get that, which creates basically a waste of all the time and effort of putting that into that solution.
Yeah, I mean, it's really kind of amazing when people do that to me, because in order to get the surgery, they need to be evaluated by a psychiatrist. They need to meet with a nutritionist. They have to show that they're really committed.
Right.
So for them to then just, completely disregard it after they've had surgery, it's dangerous if you,
Yeah.
eat a lot of food after those surgeries.
What are some of what would be some of your your opinions on the fad diets, whether it be keto, carb cycling, carnivore, intermittent fasting? And I'll go ahead and tell you, I'm a fan of intermittent fasting. I do that a lot. I also do some carb cycling. But as me, I know my body and I'm body aware, and I feel like I know what nutrients, and I also get blood tests, as I change the diets and stuff. But what are your opinions on those type of things in society as a whole? Because I know a lot of people will jump on those diet trains for a little while, see the loss in weight or the loss in body fat, but then after they hit that plateau, then they quit it and go right back and they, gain it all back.
I think that any plan that someone's going to stick to is good. People will lose weight on any of those plans. If they're going to go off those plans, then they're going to gain weight back. And it's not to say that you need to, let's say you go on Atkins or keto, you lose a lot of weight. You don't have to stay on super low carbs forever. There are plans, people can help you slowly add them back, where you might see a little bit of weight gain, but you won't see an astronomical weight gain. Do you know what I'm saying?
Right.
If you do it right, any of those diets will allow you to lose weight. And I'm a big proponent of people going on things that they could stick to. Because like I said, you're not going to put someone who lives a vegan lifestyle on an Atkins diet. I mean, is there a way it could be done? Probably. But I think it would be really hard to go the long run with that.
What are your opinions on vegan, vegetarian, or just a plain, food pyramid diet,
I think if you had to ask, I mean, vegan's obviously very healthy. I think it's hard to stick to. And I think some, they have to work very hard to get in certain nutrients that are lacking.
Right.
That they're missing from meat. But if they can do that, it's a great diet. Lowers cholesterol and all of those things. I don't think people should get caught up with eating. Some people substitute, the meat and all that, and they eat a lot of sugar and bread and stuff like that. I don't think that's a good thing. I think if you ask me what I think a great diet is, it's a low carb, high fiber diet.
Okay.
But as I said, not everyone is going to be able to stick to that.
Yeah.
And people really should be on a diet where they could stick to it. If you told me that, you want prepackaged foods to lose weight, there are diets where you could do that. Do I think that processed foods are great? No, I don't think that. But I think that them going on a diet where they're going to eat these prepackaged foods and lose weight is still healthier than remaining overweight.
Right. I completely agree, because there's people that, I've had the argument with, hey, I'm going to, let's just use said fast food restaurant for an example, like going through McDonald's, and okay, I'm going to have I'm going to go through, but I'm doing low carb. So I'm going to have just the patty instead of the bun. But I feel like going through that line at all is detrimental to what you're planning on doing as in a lifelong span of trying to create a healthy lifestyle. And when people say I'm going on a diet, also, subconsciously, I'm like, okay, well, if you're telling yourself it's a diet, it's already a temporary fix, whether it should be you're changing your entire eating habits moving forward. And in the past, when I've worked with people and training them and stuff, I've tried to say, okay, I'm going to try to train you on slowly taking one thing out at a time. Let's take out the soft drinks first. Then let's take out the deep fried foods. The things that, what I've noticed a lot dealing with clients, and I do personal training a little bit now. I used to do it a lot more, but I do it more of, I'm passionate about it. It's more like my side hustle that I really care about, but I'm not doing it for a full-time job. And I don't have multiple degrees in, nutrition or anything, but I do know what works for people if they have an issue and how to work out, and help those people. But what I've noticed the most is like diet drinks, Diet Coke, Diet Dr. Pepper, and people that are overweight. I don't know what that is, but I feel like it's not a coincidence. Even in this region anyways, I don't know about where you guys are at.
That they like the diet drinks?
Yes. And that they're really not any better.
A lot of study, well, they're full of chemicals, so there's that. But I have to tell you, I was a big fan of drinking seltzer.
Yeah.
I like the carbonation, but I didn't want to drink all the chemicals. And there was just an article on Consumer Report that came out, and it said that the seltzer that I like the best, Polar Seltzer, which has the most bubbles, has the most chemicals in it.
Really? Gosh.
So I was like, what chemicals? Everything, has something. I think it's very difficult to cut out all processed foods all at once. I think too many, like you said, harsh changes at once, people are just not going to stick to.
It shuts them down, yeah.
Right. So you can and maybe encourage them to drink one diet soda a day. There were different studies, and some people had thought that it actually spiked your insulin levels, like the fake sugars. But I think there have been other studies that show that that's not the case. It doesn't increase insulin. People are doing studies wearing the glucose monitors now.
Yeah.
To see the fluctuations throughout the day. And I think they've proven that that's not the case. But as you said, people should not be drinking too many of them just because they're processed, they're bad, they're full of chemicals. But apparently everything's full of chemicals, even things that are healthy, like water with bubbles. So.
Yeah. Yeah, well, so what are your thoughts on childhood obesity and diabetes at early age from consuming horrible foods?
I think it's horrible, and I really think it starts at home. And I struggle with this. I have 3 kids, and kids just have a radar for junk.
Yep.
I think it's really important not to give sugar-sweetened beverages. The American Society of Pediatrics recommends 0 sweetened beverages, and my kids love juice. It's like a balance, because I don't want to be the mother who, and my husband criticizes me sometimes because he thinks I'm too strict, but I don't want to be the mother who doesn't give them something and then they go out when they're not in the house, they go to a friend's house and they'll
binge
themselves or you know what I'm saying? So
yeah,
they'll get water with some fruit juice in it. Even though I believe it should have none of that, but I'm not going to completely deprive them, because it's really a balance.
Yeah, I agree. I think that, we've seen this a lot, and I'm sure the numbers, maybe some of the numbers are what we're dealing with now. And I know that we're predisposed to these things, like growing up, especially processed foods. I don't know what years those started getting really, popular, but I feel like it was probably in the 80s into the 90s.
Yeah, probably in the 80s.
Yeah, and so everyone was living a fast track lifestyle and using that as something like Hamburger Helper or, whatever it may be.
Exactly.
Box meals and I grew up on those things, or the frozen pizzas that you throw in the microwave real quick because mom's busy, and things like that. And then the soft drinks, we were drinking soft drinks every day, and
yeah, those are bad.
50 grams of sugar per 12 ounces, is insane to me, that's my entire sugar tolerance for the day now, trying to balance what I consume at the most, and it's how do we fix those things and feel like that here's another thing, kids feel like they're left out because everyone else is doing it, you know what I mean?
That's exactly the problem.
And how we just passed Halloween, you can't tell them, you're going to tell them they can only have 2-3 pieces of candy. How do we deal with that moving forward and trying to combat this as a whole?
I think education is really important. I think we need, it needs to be, as a family, that we emphasize healthy eating. And I try to limit my kids. Like I said, I don't want to deprive them because I don't want them to go in the other direction.
Yeah.
get one sweet treat a day. So if they get it when they come home from school, then they don't get it for dessert. Their dessert is going to be fruit.
Okay.
But I think it has to be as a family. I think sitting down to dinner and eating, foods that are not fast food. And again, am I saying that a kid can never have fast food? No, but that can't be the main staple of the diet.
Right.
There are foods that people can cook in a hurry that are still healthy. So, you know what I'm saying? I think we need to educate people on that.
What would be some examples, in your opinion, of those that you may use at home, so people having some examples to kind of relate to?
Okay, I mean, my kids have gotten very picky recently, but we do we do Taco Tuesday on Tuesdays, and I go to Trader Joe's. I buy the 96% fat-free meat.
Okay.
And they love that. They'll either have one shell or they'll eat it with a salad.
Right.
We have vegetables at every meal. I think that people don't have vegetables enough. And I think that, kids are not going to like them to begin with, but we have to keep exposing them to them, and maybe eventually they'll eat them. I mean, my daughter doesn't eat anything yellow. She won't go near carrots or squash. My son doesn't eat anything green, but we still put them on their plates. I mean, I'm not saying I'm an expert, but I'm saying these are like the little things that I'm trying to do, because I am aware that childhood obesity, the thing is prevention. So if a child's obese, we're not going to tell the parent, like in the early stages, there's a whole algorithm for this, which I'm not going to go over now, but you don't say, go home and put your child on a diet.
Right.
That's not the case. It's go home, incorporate these healthy activities, start, going outside and exercising, make it a family thing, healthy dinners, and try not to let your child gain more weight, not necessarily lose weight. And BMI, they look at the World Health Organization calculator for children. They'll calculate your child's BMI, but you're not supposed to go by that when they're younger.
Okay. Well, I think that, it's taking those things out slowly and then putting new things in slowly, maybe be the easy approach to all of this. But, as kids, we're predisposed to all of these bad things, and we don't really know they're bad because we're not educated. Okay. When we were growing up, it was all about the health pyramid and making sure you had enough grains and dairy and stuff like that. But I don't even eat dairy. I don't consume dairy much anymore. I don't consume a lot of gluten. What are your thoughts on gluten in a diet?
I don't think it's harmful unless you have celiacs. Okay. And I think that the more people avoid gluten, the more sensitive they become to it.
Well, that's like anything, right? The more
it is, but it's like dairy. I have a friend whose child actually has celiac. She's a twin. Right. So she, I think she was diagnosed when she was 3 years old. So she said, you know what, I'm going to make the whole house gluten-free. And the GI doctor said, no, don't do that, because your younger kids will never be able to eat anything with gluten, and they can. So don't do that to them. I think that gluten is not the problem. I think sugar is the problem, and processed foods, and whole wheat bread has gluten in it. I don't think that's a terrible thing. Right. And I think that all of these gluten-free products, gluten-free bread, gluten-free cookies, gluten-free, people think it's like a free pass, and I think they gain even more weight.
I agree. I think that there's so much stuff in that, the cauliflower pizza that has 3 times the sodium as a regular crust. What I try to do is limit the bread intake. I still consume rice, consume other things, but I think that for me, in beer as well, I quit drinking that. But I feel like if it's yeast and it has to ferment, it's probably not good to put in your body. So that's just kind of how I think about it, in my mentality. But the same thing with, if you had to size this up, because people have opinions on this, sugar versus carbs, what's your worst enemy?
I don't think all carbs are bad. I think sugar is worse than carbs. I think there are good carbs, and our body needs carbs to live and to run and to move. I mean, fiber is a carbohydrate, and I think it's really important to have fiber in your diet.
What would be some of the examples for people at home to the best way to consume fiber on a healthy level? Because a lot of people aren't getting enough, No,
they're not. So it's 25 grams a day that's recommended for an adult, at least an adult female. There's cereals. There are whole wheat bread. There are, certain bars you can eat, like all natural bars. There's one called Raw Rev Glow. I think it has it's made of nuts and natural ingredients. It has 13 grams of fiber or something like that. Fruit, vegetables have fiber. There are these many different kinds of crackers you can eat. You could substitute with bread that have a lot of fiber. There are a lot of things that you just look for high fiber. And, fiber is undigestible. It kind of goes through the body. And so some people actually subtract it and they come up with what they call a net carb. So a net carb is a carbohydrate. So let's say you have 10 grams of carbs and 5 grams of fiber. You would subtract the fiber from the carbs. The net carbs is 5 grams.
Right. Okay. So that's how they're monitoring their carb intake, basically.
Right.
So, well, answer this if you can for me. Do you know what is the once you perform or basically get someone on a plan who's obese, and let's just use an example of over 40 years old, for this example, what are what have you seen the percentage rate of them actually achieving weight loss and sustaining it?
I can't give you a percentage, but it's not high. I mean, it also depends if they've had surgery,
right,
or putting them on a diet.
I would say stack up both of them, and not necessarily a hardcore percentage of analytics, but just in your opinion, what have you seen?
Well, maybe less than 20%.
Okay.
I mean, unless they're having weight loss surgery. Weight loss surgery, it's much higher. But
right.
I mean, obesity medicine, I haven't followed someone very long term. I just started doing it.
Okay, got you. Because I feel like that, people may get discouraged because they see people, temporarily have a solution, but then not, fully get to their goal. And it may discourage them from even trying to do these things. And I'm hoping our discussion here that people can listen to it, okay, and say, okay, these are the things you need to do. These are the things you need to think about. This is what you're getting into. Know that it's going to be hard, but there is a light at the end of the tunnel, and we're trying to sustain your life at this point,
Right. I mean, I think small changes increase your fiber. If you do nothing else to your diet, if you're going to sit there and not change your diet, if you add, I think, 25 to 35 grams of fiber in your day, I think you will lose weight because it makes you full and it makes you go to the bathroom.
Yeah.
And I think it's very good thing. I think that, people should not necessarily exercise extremely vigorously with cardiovascular exercise while they're trying to drop a lot of weight. I think it makes them very hungry. I think resistance training is better.
Okay.
And then to add in more cardio, for maintenance.
Right.
Because studies have shown you definitely do need, to exercise to maintain your weight.
Yeah, I just feel like that as soon as you throw exercise in the mix of someone who may be overweight, especially if they're a good bit overweight, that it extremely, just turns them off immediately.
Right. I think it's 80% diet and 20% exercise. And I'm also a fan of, I think that if you tell someone you have to lose 50 pounds, that seems like an insurmountable obstacle.
Yep.
Have them make small changes with a goal of losing 10 pounds.
Right.
And I believe in, I guess during weight loss, a 90-10 rule, and during maintenance, an 80-20 rule.
Right.
You're going to slip and you're going to have a bad day and you can't make it the end of the world where you're going to, feel bad about yourself and then you're going to binge and then you're going to set yourself back even more. They should be allowed every few weeks or however, depending on their weight loss goals, to eat a cheat meal or eat what they want.
I have seen prep competitors in fitness go so hardcore so long, and then once they're done competing, they literally just almost lose everything they worked for because they were so hardcore on that meal plan where they were eating, chicken breasts and green beans and rice and nothing else. And then they basically want to binge and just can't stop or don't want to do it anymore. And then I've also seen people who, get to the point to where they start losing weight, they're doing well, and then they slip up that one time and they just never go back to it too.
Right, exactly. I think a lot of it is psychology as well.
Of course.
I think you really just can't set yourself up for failure, which is why I don't believe that there's one diet that's going to work for me and is going to work for you.
Yeah.
Do you know what I'm saying? And I don't think that you can drastically change someone overnight. I think you need to make small changes. I think you have to allow them to do what they want some of the time. and then it'll be easier for them to stay on plan.
Yeah, I mean, I completely agree. I think that they should start strengthening their mental basically fitness before going into this, knowing that it's going to be a struggle, because if you can't beat it here, you're not going to be able to beat it here. You know what I mean?
Exactly.
And that's such a cliche to say, but it really is true. And I feel like that's proven that you have to have the psychology to be able to stay on a plan, be able to, hold yourself accountable
I agree.
to what goals you've set. So you're part of a nonprofit. What can you talk a little bit about that? I definitely want to plug you guys and give you some.
Oh, okay. This is great. So I just started on the junior board of a nonprofit called Harboring Hearts.
Okay.
And what it does is we help cardiac patients and their families pay for hotels, for food, for transportation, basically all the things you need to support, someone in your family, but you don't want to think about or have to pay for. It's expensive, when your loved one is in the hospital or trying to beat a difficult disease. And, it's a cause near and dear to my heart. My grandmother just died of congestive heart failure during COVID, which is really sad.
Sorry to hear that.
My brother is a cardiologist, and it's just a cause I think is so important. And actually, they are having an auction. We had to cancel the benefit for this year.
Okay.
Obviously because of COVID, because we can't all be in a room at the same time. I was there last year and it was incredible. But they are having a silent auction, a live auction on November 12th, where you can bid and all the proceeds are going to go to Harboring Hearts. And there are some really great prizes and great things.
What's the website? How can I get to post that and actually let everyone know how they can be a part of that, or if they want to donate or just educate themselves on this nonprofit?
Oh, I have a link I'll send to you.
Awesome.
And if you go to my Instagram page, which is at Obesity Medicine Doc, I posted something about it, I think a week or two ago.
Okay.
But I will send you the link so that people can go on. They don't have to just flat out donate. They can bid on. We have, like I said, great prizes, and it's a really important cause.
And I completely feel for you in your recent loss. I have one living grandparent now. I've lost the past 3, all due to heart issues. Where been stroke, heart attack, and then it just went downhill from there. And these are things that I feel like, and I have no knowledge of medical other than just seeing and taking the information, but stopping and jumping on these things ahead of time, like the obesity thing and the exercise and the eating healthy, can hopefully prevent these issues.
Yes.
Oh, go ahead.
There's a lot of genetics, but prevention is key.
Right. Yeah, because I had a grandparent that was in shape, worked every day, but the diet wasn't great. You know what I mean? And then I had some that the diet was horrible, and they've been eating that way that whole life. They didn't really know any better, didn't need to make an adjustment until it's time to start taking blood thinners and things like that. You're at the point of your life, you're 3/4 away through your lifespan, and then you're having to create, make an entire life adjustment to your diet and your lifestyle. And a lot of times it's super demotivating for people.
Yeah. So prevention, early education for childhood obesity and adult obesity is just the best thing we could do.
So you guys are in New York, and I want to talk a little bit about COVID, but I don't want to get off on a negative thing. Yeah. But basically, how has it been dealing with adjusting your entire practice of how you operate? Keeping everyone's health in mind and progressing from the high volumes of cases and letting that slowly get, I guess, back to a new normal.
So you want to talk about after COVID?
Sure.
Okay. So since, I worked at a hospital where every single patient was a COVID patient.
Whoa.
We went from, doing a lot of elective surgeries every single day, because I go to a big university hospital, but I also am based now at a smaller community hospital. I changed recently, but so a lot of the cases were elective, knee replacements, bariatrics, like I said. And the change from doing the elective surgery to not, was within a week. And then we had an entire hospital of COVID patients, which I won't even get into talking about how that was. But once the numbers were down and they approved elective surgeries, my hospital that I'm based at became a non-COVID hospital. So what that means is we don't allow anyone who's even questionable into the hospital.
Okay.
Meaning, if a patient comes to the ER and they need emergency surgery, they can't come into our hospital. They have to be diverted to a different hospital in the area because we don't know their COVID status and we're quote unquote a clean hospital.
Gotcha.
If they come and they need surgery where they can wait a while, let's say they need their appendix out, we send a COVID test, we get it back within 4 hours. And then if they're negative, they come up and they have their surgery. If they're positive, then they're once again diverted. We are doing elective surgeries again, but we're not doing as many as we thought that we would be doing. We thought that we were going to be making up for the thousands of cases that were canceled. And instead, we're finding that people are scared to come to the hospital. People were out of work, so they don't have health insurance anymore. We're finding that people don't want to take a vacation or use their sick time because they used it during COVID.
Gotcha.
To have these surgeries because they need time to recover. So we're not as busy as we thought we were going to be. We're in my hospital, everyone wears a mask, including the patient, no exceptions, and nobody's allowed to come in with the patient. No one can wait in the waiting room. We used to allow in the preoperative area, someone's like a family member, so they wouldn't be scared.
Right.
None of that anymore.
I have heard that from multiple of your friends and people I know in the industry. They're saying that, that there's been a lot of backlash from relatives getting extremely angry because they can't go back with their loved one, but this is all in, for everyone else's safety, not just theirs.
Exactly.
That issue. Well, I really had a good time. I don't want to hold you up too much. You look like I may be keeping you up. I saw you on.
No, my first case today was at they called me in early. I had to be there at 6:10 in the morning. So no, I'm having a great time, but
Well, for a few other points, and then we'll shut this thing down. One thing I do want to say is normally I give my guests some type of gift, and since you're part of this nonprofit, I would love to make a donation. I'm not rolling in the dough over here, but I'll give what I can, and also
I would love that.
Share that link so everyone else can hopefully contribute, share, raise some awareness. Now, back a little bit real quick on the obesity standpoint. Basically, if you were to say, okay, so tell me this. So alcohol consumption, is that part of how does that factor into these issues? Because we didn't talk about that, and I kind of want to, because I feel like everyone who is normal day operation has a drink here and there, and then some people may have too much, and then some of that leads to bad eating, stuff like that.
Yeah, well, alcohol in itself has a lot of calories and a lot of carbs. And they're empty calories. They don't provide any nutrition, and they don't really make you full. I mean, I don't know about you, but they don't make me full.
No.
So
unless it's beer, I can't do beer.
An empty calories that can easily be cut out.
Mm-hmm.
And like I said, small changes and someone could lose weight. So if someone drinks 5 drinks in a night, which they shouldn't be, because if they drink 5, that's way too many drinks in a week. But let's say, just for an example's sake, they cut it down to 1 drink in a night, they're cutting out a ton of calories.
Yeah.
But yes, it also leads to bad decision making, overeating, all of those things. Also, I mean, as an anesthesiologist, the more someone drinks, the more anesthesia they take.
Really?
And the harder they are to put to sleep, and the harder they are to keep asleep. So I always have to ask my patients how many drinks they have. I hope they're telling me the truth, because I will find out either way.
Normally, they're probably not.
Yeah, I'll find out. You can't really lie to me when you're under anesthesia. But,
well, what about so obesity? Real quick too, obesity into sleep apnea and issues sleeping, and I know that alcohol plays a part in that, as well as diet and exercise. What are your thoughts on that?
I think so many people have sleep apnea. Yes. And there's a screening thing called Stop Bang, where if you have 5 or more of these symptoms, so stop snoring, I'm trying to think, I forget. And there's blood pressure, there's BMI over 35, there's being a male, there's neck circumference, all of those things. Let's say your neck circumference is above 17, your BMI is over 35, you're a male, all of these things. If you have 5 of them, then you're at a high likelihood that you have sleep apnea. And sleep apnea is not a great thing because you stop breathing in the middle of the night and your oxygen levels can go down really far. And when that happens, if you don't treat it, your heart can actually remodel itself. So I have a lot of patients that know they have sleep apnea, and I say, are you compliant with your CPAP? CPAP is the machine that they have to be on to kind of open their airways so they don't desaturate or, like I said, drop their oxygen at night. And they're like, no, it was really hard for me to tolerate the mask.
Right.
Well, I don't want to get into it with my patient.
I've heard that a lot, though. I've heard that. I know numerous people have said the same thing. I put the damn machine on. I can't sleep with it on. They only try it for a couple nights and they get demotivated and leave it alone. Right.
But I don't think they realize that they are, causing themselves long-term harm.
Right.
So, I mean, sometimes sleep apnea can be solved with weight loss and sometimes it can't. Okay. I want to say, I'm going on a limb and saying a lot of times it can be solved with weight loss. So you can lose weight, in my opinion, or you can wear your CPAP machine. But if you don't wear your CPAP machine, your heart is going to remodel itself and you can eventually go into heart failure after a long time.
Well, what about?
That's good. I don't think they know that. Like I said, education is really important with regard to obesity and all of these things.
I feel like that's where we're missing is for some reason it's not cool to talk about taking care of our body unless it's for aesthetics. You know what I mean? And I think
everyone loves aesthetics.
You can look as good as you want to, but if it's not internally on point, then we're having an issue here. Now, like for sleep apnea, there's other devices that people say work. What are your thoughts on those? Like the mouthpieces and the
I think anything is better than nothing.
Agreed.
And that's how I feel about diets in general. You're like, would this diet work? Would that diet work? Do I have an ideal diet that I would love to put my patients on? Yes, but I'm well aware that not everyone can live that type of lifestyle. I can't live if you told me I had to be on a diet where I had to cook every meal, I'm a busy working person. That's just not going to happen.
Yeah.
So, I think the CPAP machine is the better thing. I think weight loss is even better than that. But yes, the dental device is better than not doing anything at all.
Well, that's interesting. Good to hear because, it's one of those things that's always contested. People always have an opinion on it, but they're not trying to actually utilize either one of the solutions to not make up for anything. And then another thing I wanted to ask you about is application of medicine for obese patients versus them becoming reliant upon medicine and then demotivated to take a holistic solution first. And I know this is a slippery slope, so I'm not combating it. I'm just, for me, I'm like, I don't take any medication at all. And I'm reluctant that I'm 31 years old. I work out, I eat healthy. I don't have any, I have some acid reflux, like this hereditary, I believe, because my dad has it and I've seen that.
You should take medication for that.
I agree.
You know why? Because you can get Barrett's esophagus if you have untreated acid reflux, and that could lead to other problems. So I think that medicine has its place in society. I am someone who will take medicine. I don't take it all the time.
Right.
But if I have a cold and I can feel better,
yeah,
I feel like, why not? I'm going to take the pill. For obesity, people personally, and as I said, I just really started seeing and treating obesity patients. I'm going to open my own kind of boutique practice, and I'm not quitting anesthesia. This is in conjunction with anesthesia.
Okay.
I think there is a place for medication because, like I said, a lot of obesity can also be genetics and hormones and all of that.
Of course.
I am not someone who is going to put someone on medication unless they change their diet first.
Okay.
So I wouldn't have someone come to me and be like, "Yep, here's some medication." No, we're going to try the diet first.
That's why I brought this up.
And then we're going to add the medication.
Yeah.
And there are a ton of new obesity medications that have come on the market in the past few years, and some of them are really excellent.
Okay.
A lot of them are medications that they were medications for other things, and they noticed a side effect of the medication was weight loss. For example, Wellbutrin, which was
Heard
a
that one.
pill that, you know, people take for depression. People
Right.
noticed that people lost weight on that. So they combined it with another medication. There's Topamax, which people would take for seizures and migraines. They found that people lost weight on that. So they're also giving that for obese. There's also the two I like best are medications that they used to give to people with diabetes. One's called Saxenda, and it's just a higher dose of a diabetes medication, and people
Right.
lose weight really, really well on that. So there are actually a lot of great medications out there. I will not give certain ones to my patients. Like I said, there are some of them that have historically been used because they're cheap, but you know, people can become more dependent on them, something like phentermine.
Mm-hmm.
But I do think there's a place, but it's not to substitute a diet.
I agree that I've noticed this and I've heard it a lot, and you know, just moving around in the day to day, is that there's so many doctors out there that are quick to, you know, prescribe a medication and not get to the root issue of solving the problem, you know. And of course, if it's something that's predisposed or like, you know, hereditary, whatever it may be, that, you know, they're gonna combat these issues already. But I just think that so many people are dependent upon medication now. And I'm not against medication, because I had the flu last year right before COVID hit, and I had to take whatever that new flu medication is that they just came out with, and it worked fine. But I don't pop aspirins on a daily basis for a headache, or pop, you know, if I have a sore muscle, you know, I try to work it out first before that's like my last result. And with the acid reflux thing, I take apple cider vinegar, and it's helped a lot with that, you know. I'll take things like Nexium and stuff like that, but it really hasn't helped. And I don't like becoming dependent on something if it's just, you know, basically fulfilling, you know, making me feel better, but not actually solving the issue.
Mm-hmm.
I think there's a lot of that goes into that, you know, as far as where you're at in your industry, that you're actually sound like you're compassionate about these people that you're working with them. If you're in a specific obesity medicine, whereas some of these people are just going to a general practitioner and getting, you know, some kind of prescription and just moving on.
Yeah. I think it has to be lifestyle as well as medication. But I do think there is a place for medication.
I can't argue that at all. You know, it's one of those things where people will immediately jump on the medicine train and refuse to do anything else, you know. Right. And then you have people that are on medication and that won't take the steps to wean themselves off of it, you know, like the blood thinners, you know, because they're not getting enough their diet and exercise not on point, so their blood pressure is up, and then they're, you know, things like that. I feel like so many, I don't know the numbers or anything, but I feel like so many people that are over the age of 50 are on that medication.
Mm-hmm. Yeah.
What are your age ranges where you see, are you like, would you know these, like I guess, what's the most common age, and like male or female, when their obesity kind of is at its peak, I guess, in practice, like as far as like heart disease and stuff like that, diabetes?
I think women are, I mean, everyone's obese, but right. Women tend to come for help more than men.
Okay.
And men have more heart disease than women.
Okay. Is that, I mean, what are your thoughts on that? Why do you think that is?
I think that sometimes people don't even realize that they have an issue. Mm-hmm. And I think women care more about how they look, and I think women are more likely to be open. They're not like big and macho, and they're more likely to
yeah. Yeah, I do. I've noticed that in myself and other people, you know, is we don't go to get our checkup as much as we should, especially men. I mean, of course, you know that you can talk to someone and they haven't been to the doctor in over 10 years.
I know, but that's not good, because you know what? When they finally do, they're going to have a bunch of problems. Instead of, like I said, prevention, mm-hmm. combating them before they start to develop or at the beginning stages.
I've noticed that a lot with friends and families who had older relatives that are diagnosed with cancer, and they're too late of a stage to save them, because they haven't been going to get their checkups or routine, or, you know, may have had a bad cough and had lung issues for 2 years, but really didn't go see about it. And then they get checked up and there's a stage 4 lung cancer. And I've seen.
I think that's a travesty, because, you know, I'm not saying lung cancer is something that, but you know, if you catch it in the early stages, it's treatable.
Yeah.
So
I've seen it in numerous people that that are close to me, that it's happened to their parents or grandparents or whatever. And it's just like, gosh, we got to get out of this mentality of quit being a hard ass. And if we need to go to the doctor, we need to take care of our body, and it's one of those things that it's just it goes hand in hand with the other things, whether it's obesity or, and so for diabetes, I know there's different types of diabetes, but typically, where does it develop once they become obese? What type is that?
it's type 2 diabetes. So a lot of them are insulin resistant. And again, if you catch in the beginning stages where their A1C or their fasting glucose isn't too high, you can start with diet changes.
Right.
And if they're very compliant with that, maybe their A1C drops and they don't ever have to go on medication. But typically that doesn't happen, and people have to add, oral medications.
Now, once they're on this medication, say they make a complete lifestyle change, is there a way to combat it to where it goes away? Is that even a thing?
Yeah, with type 2 diabetes, you lose a lot of weight. Like I said, the gastric bypass solves diabetes, I think, in like 80% of patients.
Okay. Yeah, because I'm not aware of, how that all works, but I do know that it's directly related to obesity. And, I didn't know the bounce back, because honestly, I haven't seen too many people who had problems with diabetes who overcome it. A lot of people that I know who do have it are older and overweight and just aren't interested in combating it, basically.
Yeah, people don't keep their blood sugar in check. And I guess I'm not even sure if they're not aware or they don't care that it can lead to horrible things. It could lead to blindness. It can lead to limb amputations. It can lead to kidney failure. So,
well, I think it's a society where basically we're like, okay, well, we're getting old. We should feel bad. You remember your grandparents or your parents or whatever, when they get old, they're like, oh, my back hurts when I get up. You know what I mean? And maybe subconsciously we're just like, okay, I know I'm supposed to feel bad because I'm older, but I don't think that's the case. And I feel like maybe that'd be, something there too.
I mean, it's a different generation.
Yeah.
I feel like our grandparents went to the doctors just less.
Yeah.
It wasn't as common of a thing. And I mean, I think this generation should be all about prevention and stopping things in their tracks and, not letting them get bad.
Well, we're all about instant gratification and no accountability as a whole, I feel like. So we need to make a shift. We got to make a shift before we can actually do something, and I don't know. I'm trying to be an advocate for it. I wanted to talk to you about it today so we can spread a little bit of awareness about these issues and also about your nonprofit. And can you say the name of that nonprofit one more time?
Harboring Hearts.
Okay. Now, are there any things before we shut this thing down any points you may want to make? Any quotes that you may like to live by? Any final thoughts? Any plugs that you may have?
Like I said, I think small changes get you ahead in the long run. I think moderation is key, and I think education is the most important thing, as well as prevention.
I couldn't agree more. I want to thank you again for coming on. It was a good time.
Thank you for having me. This is awesome.
Yes, ma'am. Everyone, please subscribe to the podcast.